Good evening and welcome to Doctors on Call. I'm Dr. Peter Nalin, Professor and Head of the Department of Family Medicine and Biobehavioral Health and Associate Dean for Rural Medicine at the University of Minnesota Medical School, Duluth campus. I'm your host for our program tonight on upper extremity, neck, and back problems. The success of this program is very dependent on you, the viewer, so please call in your questions or email them to ask@wdsc.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Chris Davies, a pain management specialist with the Pain Clinic of Lake Superior, Dr. Matthew Davies, a neurosurgeon with Orthopedic Associates of Duluth, and Dr. Sandy Stover, a family medicine physician and faculty member at the University of Minnesota Medical School, Duluth. Our medical students answering the phones tonight are Kayla Egnes from Alexandria, Minnesota, Caitlin Henningsen from Hermantown, Minnesota, and Logan Hooker of Sandstone, Minnesota. And now on to tonight's program on upper extremity, neck, and back problems. And the first question is for Dr. Stover. How is a shoulder dislocation treated?
Well, a shoulder dislocation needs a treatment right away to get the ball of the joint back into its socket. But the process of dislocation will often injure some of the ligaments and muscles around that area. And so the first step is letting it heal, and then physical therapy to get the tone back in. Sometimes surgery is needed if the tears in the soft tissue have been more disruptive and it needs to be rebalanced. So it can take a while. Shoulders can be slow to heal.
Dr. Chris Davies, how does a neck problem cause pain beyond the neck?
That's a really great question, and we get that from a lot of our patients. And the neck is composed of many important structures. The cervical spine, which is a primary area of focus for me, has a series of bones and ligaments, and most importantly, nerves. And it's those nerves that can cause pain to radiate beyond the neck itself and down into the arms predominantly.
Okay, thank you. And Dr. Matthew Davies, what imaging usually precedes your neck or back surgeries?
That's an excellent question. It's very common for patients to have both x-rays and MRIs of their neck prior to surgery. X-rays are good at looking at the bony structures, and MRIs are good at looking at soft tissue such as disc or nerves.
Thank you. Dr. Stover, how would you initially evaluate a tremor or shaking in one hand?
And that's a kind of a complex question because sometimes that shaking can come from nerves that are getting a sort of a missed message to the hand for a number of different diseases, Parkinson's disease being one. Sometimes tremor is a natural sort of process of the aging of the tissue. You can also have issues of the muscle weakness that can cause tremor when you're trying to do something. So the first step is just looking to see is it more muscle or nerve by testing both of them through a physical exam and things like a electromyogram that looks at muscle innervation or how the nerves feed the muscles and make them strong. So it's a little bit of a complex one, and if people have a one-sided tremor, it's really a tremor on either side or both should be checked out by their doctor to make sure that what's going on is something that can be helped, or there's ways of sort of accommodating so that it doesn't bother. Tremors can sometimes cause problems when you want to write or bring in a cup of tea to your mouth, and so there's a number of things that can be done for that.
Thank you. And next, a surgical question. How do you safeguard that surgery is performed on the correct side of the body?
So prior to every surgery, we mark our patients, whether it's directly on their skin or on a marking sheet, depending on where we're doing surgery. This is double checked throughout the preoperative process by many people, including the operative nurses, myself, and other staff that's in the room.
Okay, thank you. Dr. Chris Davies, perhaps this one for you. Does cracking your neck or back cause further damage or pain, or is it beneficial?
Oh, that's a really great question as well, and it's an old wives' tale where you crack your knuckles and it leads to further arthritis. The same thing can happen in the neck, where the actual cracking sound is typically just the fluid in the joint moving throughout the joint space itself and does not necessarily cause damage or further damage if there's underlying damage already.
Okay, thank you for that. Another question, Dr. Stover, why does side sleeping cause neck pain?
Well, that's actually kind of interesting if you think about the dynamics of what happens when you lay down in bed, whether it's on your side or your back. It's the alignment of your neck in a more straight line, which is sort of the neutral place for your body to lay. So it may be more related to the angle of the pillow or the angle of the softness or hardness of the bed that's changing and making things uneven. And then stressors happen, you get some muscle cramping, and that can be problematic. So actually get a bed that works well for your body type, and making sure you have a pillow that keeps the head in an alignment with the spine is the most likely way to help keep neck pain from happening from sleep positions. Unfortunately, sometimes it's just stiffness from being in one position for a while too, and that's a hard one. I think I'm the oldest in the group here. It's a little hard as we get older because some of our natural stiffness can wake us up at night too, just from not having moved for a while.
Is it that some pillows are too large or too thin?
The angle of the head to the shoulder, and this varies body by body. Too often, if we're at an angle when we're sleeping because the pillow is doesn't take up enough space, or too bent over to the other side because it's too big a pillow is the problem. So it's about the alignment of the neck. If you think of me, instead of being vertical, if I was horizontal, this alignment is the most neutral and best alignment for the pressures of the muscles and ligaments.
That makes sense.
Yeah.
Dr. Matthew Davies, what determines the approach to surgery from the front or the back?
So the approach is dependent on the type of problem that you're having and what location in the spine that problem comes from. So surgeries approached from the front are typically from the disc space, as the disc itself is more in the front part of the spine. Surgeries approached from the back often have to do with the joints, which are more in the back part of the spine, or muscles or ligaments that are back there, often related to trauma.
Okay, thank you. Dr. Chris Davies, what are one or two new developments in the pain management procedures?
Another great question, and it's something I discuss with my patients on a regular basis, that we're always looking for new and innovative therapies. There are some tried and true therapies for neck pain, and when patients get to me, it's typically because they need some sort of intervention. As an interventional pain specialist, I focus predominantly on injections, but do a variety of other procedures as well. One of the more novel approaches to treating neck pain, specifically from arthritis, is something called a radiofrequency ablation, where we use heat to essentially destroy the nerves that provide the sensation to the facet joints in the neck, which can cause pain relief or alleviate pain for anywhere from 6 to 18 months if you look at Mayo Clinic literature.
When you're speaking of injections, what are one or two or three of the most frequently injected compounds or medications that you're actually injecting?
Yeah, absolutely. So if you look at traditional pain management, it's frequently a combination of a local anesthetic numbing medicine and a steroid such as cortisone or a similar compound. There's newer developments coming out about this whole field of regenerative medicine, where we're actually using our body's tissues to heal itself. That would be something known as platelet-rich plasma, or even stem cells, where we harvest them from the body, process them, and then inject them into damaged areas.
Fascinating. Dr. Stover, a caller wants to know, can neck pain or neck injury cause vertigo?
That's an interesting one. So our balance, what the perception of vertigo is, having like the room spinning around you, is probably the most common designation. And the place in our body where that kind of sensation comes from is really more in the inner ear area. So in terms of neck issues, you actually can have a small kind of stroke in the back of the head, which is at the top of the neck, that can cause vertigo, but that's really a vascular issue. So the neck does not have as much role to play directly in how we sense balance. Although with bad balance in our back, it can make it easier for us to feel unsteady. Does that make sense? But vertigo of spinning is really more of coming from the brain and from the inner ear, and how it's being interpreted by the brain.
Dr. Matthew Davies, how do you approach a patient who's already had a surgery in the part of the body where you're proposing to offer surgery again?
So there's a bunch of different ways to approach that problem. First would be, if possible, to look at what their preoperative problem was prior to their original surgery. Helps to kind of gather the thought process that went into their original surgery. And then updated imaging is very important, whether that be a new MRI, X-ray, or frequently we use CT scans to look at the bones in more detail in those situations, especially if it was a prior fusion surgery that had taken place, to make sure the original surgery had healed properly and how best to approach a new surgery.
To help patients understand, how do you usually explain that you are a neurosurgeon and the group name has the word orthopedics in it? Does that question come up?
Yeah, that comes up quite frequently. There's a lot of give and play in orthopedics and neurosurgery. So there's two different approaches to becoming a spine surgeon. One is traditionally through neurosurgical training. Neurosurgical training is both brain and spine surgery. Orthopedic surgical training is joints, and then a fellowship after graduation in spine surgery. And so there's a little nuance to it, but we all kind of practice within the same realm.
Thank you for explaining that. Here's one from a caller. What could be causing a sharp pain that shoots up from the back of the neck to the occipital bone, over the head, and to the eye? What could be causing such a sharp pain?
Yeah, there's a phenomenon known as occipital neuralgia. There's a bundle of nerves that runs along the back of the head in what they call the occipital ridge, and then traverses over the top of the skull and into the forehead, actually causing a very similar constellation of symptoms that you were just describing. So an occipital neuralgia. And there's a variety of different treatments for that. Sometimes you would start off with medications, and frequently you would see that in patients that have had a prior trauma to the back of the head.
Again, fascinating. A caller is been diagnosed with a bone cancer and wondering how or what to expect for radiation to the neck.
I can do my best at explaining that. So bone cancer is a pretty big term. And so if they've been offered radiation already, I'm sorry to hear that, first off. And radiation is often an upfront treatment for that. There's a lot of different approaches to radiation therapy, whether it's proton beam therapy for particular types of bone tumors, or more focused radiation called gamma knife radiation can be used as well. But often it is a multidisciplinary approach. So people that have cancer within the bone of the spine often are going to be managed with oncology team and often a surgical team in tandem in case surgery is needed as well.
Great. And this next caller wants to know, can a stenosis of the vertebrae cause tremors from the brain, specifically originating at the thalamus?
The artery that would be affected in the neck would more frequently be the vertebral artery. It's an artery that supplies brain to the back part of the brain, specifically the brainstem and the cerebellum, not so much the thalamus, which is a little bit further forward in the brain. So in theory, it could happen, but there's also carotid arteries that live in the neck as well, which is really outside of the spine, but within the neck structures. And the carotid artery supplies blood to the front part of the brain. So if there's narrowing in that region, it could affect the thalamus.
Thank you. Dr. Stover, some patients wonder whether they have carpal tunnel. How do you approach that evaluation?
Well, the carpal tunnel is actually kind of in an area right in here where the body has sort of protected all the tendons and ligaments and blood vessels and nerves that feed the center part of the hand. And so that bundle of sort of, it's almost like a little belt that holds it in place and protects it, can be sometimes too restrictive. So what is in that area, which is usually the median portion of the nerves and blood vessels, can get squished a little bit. So that can cause numbness, tingling, sometimes some shooting pain, or some feeling of weakness in the hand. So the evaluation is first a physical exam to see if there's signs of any trouble, and a couple of signs of where those nerves can get stretched and tingle when you tap on the wrist right over that carpal tunnel. And then using an electromyogram or a way of checking to see if the nerves have a reduced signal going to them can say if the compression has been to the point where it's helpful to open that up. And so that little belt that's in there can be snipped open. And these days, it used to be, I'm feeling old tonight, it used to be there was a big Z cut, and for those of us my age who remember that doesn't happen very often anymore. It's under arthroscopy now, so very minimal incision. And that opens it up to let the full use of the nerves and blood vessels that go through that area. And so it's important to do that before there's any significant weakness in the hand, because you don't want to lose that ability to keep that strength going.
Are there any conditions that might lead a patient to present with it on one side or both sides?
Anything that creates tightness in there. So some people have a predilection if they have arthritis already, or if they've had a previous injury that may have left some scar tissue in there. Repetitive issues can also cause the trouble. So anyone who has something where they're flipping the hand or doing a lot of up and down. Sometimes people who do a lot of keyboarding will find that repetitive, constant thing can make it more likely to have swelling develop in that area.
Dr. Chris Davies, a caller is unable to lay down flat. Could this be due to an issue in the neck or the shoulders?
Short answer, absolutely. Yeah, that would require a full history and physical exam to sort out exactly what's going on. But yeah, there's a variety of different cervical spine neck issues that could prevent you from laying flat, typically due to pain. So it's more so the pain than a structural issue, but there is significant curvature that can happen of the spine that could also prevent you from laying flat.
Okay. And Dr. Matthew Davies, how has the post-operative recovery of patients with neck or back surgery improved or speeded up over the years?
Yeah, there's been some pretty remarkable changes recently in surgical techniques for the neck, and very frequently patients can often expect to go home the same day after surgery these days, whereas most surgery on the neck used to be thought to be an inpatient-only problem. You'd have to spend a day or two or more in the hospital. A lot of that has come with the advancements in pain management post-operatively, and thanks to people like my brother, and being able to help manage the post-operative pain, which was often the hardest thing to control and the main requirement for staying in a hospital. There are different types of injections that can be done either before or after surgery that help pain management considerably for the first 24 to 48 hours, in which case people can recover in a place like a surgery center and then go home the same day.
Great, good to know what to expect. Dr. Stover, I think your answers have generated some questions about pillows. So
Okay.
I'll give you these. There's about 3 questions. I think they're related. Is a water pillow good for neck pain? When sleeping on one side, what kind of pillow would be recommended? And perhaps what type of material would the pillow be made of?
Those are all good questions. It's hard to generalize to all body types because even if you see us sitting here, we have 4 different neck types here, and so what's ideal is to be in a position again where your body has as little strain as possible across that line from your low back all the way up into your neck. And so for some people that's going to be something along lines of a foam. You can kind of see the pillows are built so there's a wider part and then a narrower part so your head fits in between those 2 curves. For others, using something like some of the kernel pillows that are a little bit more rigid, and this is a preference issue more than anything, what feels right to you. I wish there was a way we could give a prescription to people to say this pillow will work for you, but I think it's to some extent it's trial and error. Thinking and with having someone else look at how you're laying down, but trying again, sometimes it's not just the neck that needs to be supported, but sometimes a pillow between the knees so that the pelvis is lined up. A little more common in women to have that issue than men. Sometimes when you're laying on your back, having a pillow under your knees to flatten the low back can also make it much more comfortable to sleep. And again, Sometimes this means that you have to try something. I will say in our house we have a number of different pillow shapes that have been tried over time, and just when you feel like things are working well, your neck or body may change position, or your bed may need to be readjusted to have the right contours to support that position too. So it's kind of complicated, but I know that we're lucky in town we have some good places that sell bedding that can help allow you to try out a bed and see and help see if that alignment is a little bit more in that nice horizontal plane.
Sounds like that alignment is.
Yep. And again, about every 8 minutes we make a major body motion when we're sleeping, and so you can get just right and then fall asleep, and your body you're not even awake as it happens, but moving around. So sometimes you wake up feeling more stiff because your position has changed into one that may be a little less, ideal.
Dr. Matthew Davies, would patients present to you with trigeminal neuralgia? And is that a condition that you would treat?
That is a condition that is treated by neurosurgeons. At this point in my career, I'm not treating that condition, but that condition is often from irritation to a nerve in the face or the side of the face called the trigeminal nerve. There are a variety of different reasons that you can have pain related to that. One of the most common mechanisms is a blood vessel that irritates the nerve. There are a variety of different approaches that can be taken to treating that, from medication management to actually going through a needle incision that goes through the side of the mouth and damaging the nerve itself to trade pain more for numbness. And then there are more invasive approaches. There's a technique called microvascular decompression, which goes through an incision in the back of the head. A little window is made in the bone, and that blood vessel is actually padded away from the nerve, which has quite remarkable results most oftenly.
Padded away? What is that?
A small little piece of foam or variation of that is placed between the blood vessel and the nerve to keep that pressure and irritation off of the nerve, and often can instantaneously relieve the trigeminal pain.
Is it unusual for patients to wonder how you actually get through that bone?
They often ask that question, and we won't get into the graphic detail this evening because I don't think most people want to hear it, but there are plenty of videos online if people want to look at that.
All right. Dr. Matthew Davies, what treatment would be best or recommended for a fracture in the vertebrae due to osteoporosis?
So that again kind of comes to one of the original questions we had as to approaches to surgery. So fracture in the spine can be in the body of the bone itself, which is again near the disc in the front, or you can fracture the spine in the back, which either is called the lamina or the spinous process area in the back part, which can be fractured as well. And so the treatment approach is based off of where that fracture is located.
Okay, thank you. The next question is about suspicious nodes in the neck and someone getting an MRI. What are potential diagnoses? Anyone want to take that one?
That's a good question. So when we use the word nodes, we're usually referring to lymph nodes. And if the word node can sometimes refer to other swellings that are coming from other tissue that's growing where it probably shouldn't be growing. And so you had mentioned earlier with MRIs, they look great at soft tissue, and using an MRI can help differentiate the kind of density of tissue you might have in a regular, normal, healthy lymph node, one that's a little inflamed because you've got an infection, or one where there's something growing in it, which could be more along the concerns of a cancer. There even are fatty nodes that show up in our neck sometimes called lipomas. So the nice part about having an MRI is it can really help differentiate and also localize it, so it can have a biopsy done of that area, making sure it's an easily accessed kind of an area in the neck. When I was in anatomy, we called it the high rent district in the neck, because there's a little bit of close neighbors in there in terms of important structures of nerves, some of the major blood vessels, and some important breathing apparatus in there. So you want to know the anatomy really well before you enter in a biopsy, or obviously in surgery you guys have it well mapped before you go anywhere near anything there, I'm sure.
Thank you. And briefly, are there new or developing treatments for migraine?
There are, yeah. migraines are predominantly managed with medications and typically managed by a neurologist. I do have a little bit of exposure to patients with headaches, and it's really important to narrow down the specific type of headaches. There's 3 or 4 basic types of headaches, but if you really dig a little deeper, there's 50 to 100 different types of headaches, if not more. In terms of migraines specifically, some people start with over-the-counter anti-inflammatories. There's 2 different classes of medications for migraines as well. There's either a preventative or what they call an abortive, where the migraine has already come on and we need to nip this in the bud.
Okay, and quite briefly, I think we have time for one more question. Caller encounters scoliosis for 14 years. Would the spine continue to move out of alignment, or will it stop at a certain point?
So similar to the headache question, there are a variety of different types of scoliosis, whether it's adolescent or, as one category, in another category we call degenerative. The adolescent scoliosis often arrests once there's skeletal maturity, or if it's been treated prior to that, whereas the degenerative type is something that unfortunately is a lifelong process. As the elements of the spine change, the scoliosis change over time.
Thank you. Well, I want to thank our panelists, Dr. Chris Davies, Dr. Matthew Davies, and Dr. Sandy Stover, and our medical student volunteers, Kayla Egnes, Caitlin Henningsen, and Logan Hooker. Please join Dr. Mary Owen next week for a program on heart problems and high blood pressure, when her panelists will be Dr. Catherine Benziger, Dr. Mark Erhard, and Dr. Addie Vittorio. Thank you for watching. Good night.